I have started discussing about vector-borne diseases, right? So I have already described about dengue, and this is another class. This is about malaria. So another very important vector-borne disease that is highly prevalent in our country, specifically in our state, West Bengal. So you already know about malaria, the microbiology of malaria and the vector of malaria, right? From your microbiological class, right? So what is the etiological agent of malaria? So this is a parasite, right? So this is a parasite borne disease, okay? And vector of malaria, Anopheles. So there are different species of Anopheles. They are prevalent in different parts of our country, okay? So if we look in the epidemiology of malaria, globally it is highly prevalent. Around 263 million individuals were infected with malaria in the year of 2023 globally. So the number of the infection is more than that of its previous year, 2022. And simultaneously, in 2024 and 5, the number is even higher, okay? And the deaths from malaria is was around 6 lakh in 2023. 90% of the deaths were due to Plasmodium falciparum malaria and was due to severe malaria, okay? And so 94% cases were from the African region. So Falciparum is responsible for around more than 90% deaths globally. Sound asleep. And Vivax has the widest geographical distribution. Okay. So this Plasmodium vivax distributes through the region of Asia and Africa also, and certain parts of Europe also, okay. But this is not, the deaths are not due to solely Vivax, but mostly due to Falciparum malaria. So the global technical strategy is to reduce the incidence and mortality of malaria by the year 2030 at a rate of 90%, okay. So this is an important consideration. There was emergence of K13 mutation in Plasmodium falciparum group that resulted into artemisinin resistance. So this is an emergence actually danger, okay. So now regarding the Indian epidemiology, in Indian part, the mostly dominant species is Vivax than Falciparum, okay. So Vivax in West Bengal itself, Vivax predominates than the Falciparum group. The Plasmodium falciparum dominate in the area of Odisha, Jharkhand, Chhattisgarh and the northeastern states, whereas the Vivax dominates Gujarat, Rajasthan, Punjab and Karnataka. So what are the species of Plasmodium? One is Falciparum, one is Vivax and Malaria, next Oval, next Knowlesi. So the least actually epidemiologically least important or least prevalent is Knowlesi, but still Plasmodium knowlesi is prevalent in the area of Andaman, okay. So the peak of the infection we can see at around the post monsoon, that is around from June to the late June to early November. In this part of the year, there is a massive case surge during the monsoon area. So definitely, just like other vector-borne disease, malaria is also a notifiable disease. Regarding the vectors, most common two vectors are Anopheles culiciferans and Anopheles stephensii. So one is in urban area and another one is in rural area. Okay. There are many other vectors like Fluvivitalis, Minimus, Dirus. So these are prevalent in the forest area or in the hilly area as well. So this is a very important table reflecting the difference between the Plasmodium species. So the most common are two, that is Vivax and Falciparum. So preference of RBC, that means there are three different stages of malaria. One is mosquito stage, second one is liver stage, another one is erythrocyte stage. So during that erythrocyte stage, the Plasmodium falciparum prefers erythrocyte of any age group, mature or immature, just like Knowlesi. So Falciparum and Knowlesi, they prefer any age group of the RBC, whereas the Vivax prefer mostly reticulocytes, that means young and immature RBCs, and the Malari prefers senescent or old RBCs. Regarding the fever pattern, Falciparum, the fever periodicity of fever is not specific in case of Falciparum. Whether in case of Vivax, Malari, so in case of Vivax, the fever comes at an interval of 2 days or 48 hours. So this is called as the Tertian malaria. Whereas in case of Plasmodium malari infection, the periodicity is 72 hours. That means 3 days. So this is called as quartan malaria. And in case of Knowlesi, the fever appears every day, daily. Okay. So unlikely in case of Falciparum, there is, so in case of Falciparum, in the late stage of Falciparum, after 3 to 4 days of infection, the periodicity is same just like Vivax, 48 hours duration. But at the initial stage of Falciparum, even the fever can come daily, right? So why? I'll discuss it later. Okay. Hypnozoites. So hypnozoites, what are the hypnozoites? That I will discuss. Okay. But hypnozoites result in further relapse of malaria. So hypnozoites can be seen in case of P. vivax and in P. oval. So in these two malaria are can frequently relapse, even after months, after days, or even after years also. Severe malaria and high parasitemia, these both entities are very common in case of only Falciparum malaria. Okay. So severe malaria that may affect the other organs such as cerebral malaria, such as hepatitis, such as acute kidney injury and hemolysis also. So these all entities we can see in case of Falciparum malaria. This is why the mortality rate for in case of Falciparum malaria is the highest rather than in Vivax malaria. So the incubation period of Falciparum malaria roughly around 10 to 14 days. In Vivax malaria it is around 15 days, but definitely can be up to 2 months as well. In case of malari, the median incubation period is around 20 days, 20 to 30 days. Okay. So now the life cycle of Plasmodium. I think you know better than me because you have just read out in your microbiology class, right? So there are 3 stages. One is mosquito stage, one is liver or hepatocyte stage or exoerythrocytic stage, another one is erythrocytic stage or RBC stage, right? So this is the cycles, okay, this is the stages. So mosquito injects sporozoites into our body. So these sporozoites invades the hepatocyte by CSP, a specific protein inside the sporozoite. They invade into the hepatocytes, okay. Then some sporozoites mature into scisons. So these scisons transform into merozoites. So in case of Falciparum malaria, from each scion there may be 10 to 40,000 merozoite, release of merozoite, okay. So these merozoite resides in the hepatocyte, and after certain period of time the hepatocytes ruptures and the merozoites release into the blood circulation. But in case of Vivax and oval, there are hypnozoites. Some of the sporozoites may not transform into the scisont. They form the hypnozoite and resides forever inside the hepatocyte. After certain period of time, maybe months or years, these hypnozoites causes relapse of the fever, relapse of the malaria, right? So primaquine is the drug that kills those hypnozoites and prevent the relapse. So in case of Vivax malaria, we should use the primaquine, but not in case of the Falciparum malaria, right? So this is a exoerythrocytic cycle, and after releasing the merozoites into the blood circulation, these merozoites enters into the RBC, as I have already described about the preference of RBC. In case of hello, ekটু আস্তে কথা বল. In case of Falciparum malaria, they can infect each and every stage of RBC. Maybe young RBC, that is reticulocyte, maybe old RBC or the new RBC also. Okay. So, but in case of Vivax malaria, they only infect the immature reticulocytes, right? So now the erythrocytic stage begins. So these merozoites enters inside the RBC and they form the ring trophozoites. So these ring trophozoites further divides in scisons, okay. Then from scisont the RBC is packed with the full of scisont, and this scisont and merozoite, the scisont also matures into merozoite. So this scisont and merozoite, they actually proliferates inside the RBC, and that leads to rupture of the RBC. So that rupture of the RBC and release of the merozoite and scisont into the bloodstream, that determines the periodicity of fever. That means in case of Plasmodium vivax malaria, the scisons and the merozoites ruptures the RBC after 48 hours of infection. That is why there is a periodicity of 48 hours. Okay. But in case of Falciparum malaria, as they infect any kind of RBC at any stage, so there is no predisposition to the young RBC or old RBC. That is why the rupture of the scion, timing of the rupture of the scion is not as the Vivax malaria. It is not fixed. That is why in case of Falciparum malaria, fever can come at any point of time, any day, not necessarily after 2 days. But yes, after 3 to 4 days, when the body adjusts and the parasite actually adjusts with the body, then the periodicity will be of 48 hours in case of Plasmodium malaria, Plasmodium falciparum malaria, right? So this is the life cycle, as I've already mentioned about the hypnozoites and trophozoite. This is the erythrocytic cycle, okay? So then some of the merozoites differentiate into gametocytes. Those gametocytes circulate in the blood and taken up the mosquito at next bite. Then this cycle continues, right? Then this is a mosquito cycle. So what is the pathophysiology of the disease itself? In case of malaria, specifically in case of Falciparum malaria, there are profound anemia or hemolysis. Why this anemia occur? Why this hemolysis occur? So what is the mechanism? So there are different kind of mechanism of anemia. One, that is direct rupture of the RBC by the parasite load. This is the first one. Second one, those infected RBCs are taken up by the spleen and destroyed by the spleen. That is why there is a splenomegaly. And that, if the cycle continues, then that leads to hemolysis. Third one is, this is not, so these two are the cause of hemolysis, hemolytic anemia. But in another form, due to infection, there are release of the cytokines. We all know, in case of any infection, those cytokine suppresses the bone marrow, affect the bone marrow. That decreases the production of RBC and platelet as well. That leads to thrombocytopenia and anemia, right? So this hemolysis, after this hemolysis, there is hemoglobinuria that leads to black colored urine. That is why this is called black water fever, okay? And these lysed RBCs often stuck into the glomerulus. That leads to acute kidney injury. So hemoglobinopathy, hemoglobinuria followed by acute kidney injury. So now cytokine storm, just like other infections, after rupture of the RBC, there is release of merozoites happen and release of this toxic hemozoin. This is important. This is the pathophysiological mechanism. Hemozoin and GPI anchor protein, they are released into the bloodstream. So they activate the innate immunity, increase number of cytokine, interleukin 1, 6, TNF alpha. These three are the main cytokines. So TNF alpha decides the severity. If there is a number of increase of TNF alpha, then this result in severe malaria. Interleukin 1 result in fever and interleukin 6 result in cytokine storm. So these all are the cytokines. Then one of the most important and interesting mechanism, I have already discussed about the Falciparum malaria. Why it is severe? Why the Vivax is not severe? Why the malaria is not severe? Why only Falciparum malaria is severe? Any idea? Because two distinct mechanisms, that is cytoadherence and sequestration. This is specific in case of Plasmodium falciparum malaria. What is this? Cytoadherence. The name itself suggests. Cyto, that means cell. Adherence, that means adhere to that cell. Okay. So that in Falciparum malaria, in Falciparum, these parasites actually releases certain kind of protein. that is the adhesion protein, that is termed as PFEMP, Falciparum erythrocyte membrane protein 1. So this is a hook-like structure. After invading the RBC, into the RBC, these parasites release this kind of hook-like EMP proteins. Okay. So by that hook-like structure, they adhere to the wall of the capillary, endothelium of the capillary. Right. So suppose the blood, actually what happens? In the blood vessels on inside the capillaries, the RBCs actually flow. Okay. So from that blood vessel, the RBCs can go into the spleen, resulting in destruction of the RBC and destruction of the parasite as well. Okay. So this is a wise mechanism of Falciparum. They avoid splenic destruction. So by that cytoadherence, by that hook-like structure, formation of the hook-like structure, they adhere to the capillary endothelium. Okay. So these RBCs adhere to the endothelium. Inside it, there is a Falciparum. So that RBCs and Falciparum cannot go to the spleen. Okay. Further, these RBC, this infected RBC itself forms a rosette. So it invites the other infected RBCs and they form rosette-like structure. So these rosette-like structure adhered into the capillary endothelium, that decreases the blood circulation inside the capillary, that result in hypoxia, right, and cell damage. So in case of each and every organ, in case of cerebral malaria, in brain capillaries, in renal capillaries, in hepatic capillaries, so in all the type of capillaries, these cytoadherence and these rosary formation are happening, that result in necrosis, ischemia of that organ, result in damage of that organ. So this is why only Plasmodium falciparum malaria can cause severe malaria. Okay. And there is another mechanism, that is sequestration. So those infected RBCs that is adhered to the capillary endothelium, they are sequestered in brain causing cerebral malaria, lungs causing acute respiratory distress syndrome, kidney causing AKI, and even placenta causing placental malaria. So that they cause microvascular obstruction, local hypoxia and endothelial damage, result in organ damage. So cytoadherence is definitely unique phenomena to falciparum. Okay. So যদি তোদের কোনোদিন cerebral মানে বেসিক্যালি লং কোশ্চেন কিন্তু আসে রিগার্ডিং দ্য সেরিব্রাল ম্যালেরিয়া, একটা কেস সিরিজ দিয়ে দিল, দে ডায়াগনোজ দ্যাট কেস অ্যান্ড pathophysiology of cerebral malaria. This is the pathophysiology of cerebral malaria. Okay, this is the mechanism of cerebral malaria. So now clinical features. So just like every other infections, in case of uncomplicated malaria, the clinical features are fever, definitely fever with chill or rigor, and other constitutional symptoms such as myalgia, arthralgia, vomiting. In case of malaria, there is splenomegaly, right, and hepatomegaly may be there, jaundice in some cases, and nausea, vomiting and anorexia. Okay. So what will be the laboratory findings? The complete blood count may show anemia, maybe hemolytic one, thrombocytopenia and even leukopenia. So thrombocytopenia and leukopenia are due to the bone marrow suppression by the cytokines, and anemia may be due to the hemolysis, as I have already mentioned the mechanism. Okay. So definitely LDH lactate dehydrogenase may be elevated, as this is a marker of hemolysis. Unconjugated hyperbilirubinemia may happen because of the hemolysis, hemolytic jaundice. Acute kidney injury that result in increase of creatinine more than 0.5 in 48 hours, or decrease of urine output less than 0.5 ml per kg per hour. Hypoglycemia, definitely this is a feature of severe falciparum malaria. Hypoglycemia. So why hypoglycemia? What is the mechanism of hypoglycemia in falciparum malaria? In Vivax malaria, definitely hypoglycemia may happen, but rare. Most commonly, it is a common feature of severe falciparum malaria. Why? Any idea? Because these parasites are habituated in anaerobic glycolysis. So they use at least more glucose than other parasites and the other bacteria. So because of they undergo anaerobic glycolysis. So this is why, and one is this is the phenomenon, one phenomenon, right, by the parasite. Second one, because of the infection itself, because of increased number of cytokines, because of the hepatocyte damage, there may be hypoglycemia. And next one, very important one, because of the quinine use. Quinine can cause hypoglycemia, just like sulfonylurea. This is the same mechanism. Hyponatremia, this is uncommon, and ESR CRP, these are the markers of infection. In any infection, ESR CRP may be elevated. Okay, this is not specific one. So the classical malaria paroxysm. So the malaria, clinically, the malaria can be divided in 3 stages. One is cold stage, next one is hot stage, and third and the final one is sweating stage. So why these 3 stages? Cold stage happen. This is a fever. Why cold stage? Because release of the cytokines by the these parasites, specifically interleukin 1, 6 and TNF, they set the hypothalamus temperature set point, hypothalamus temperature set point in 40 degrees centigrade. So the normal hypothalamus set point is 37 degrees centigrade, normal human being. But the set point they set by those cytokines from 37 to 40 degrees centigrade, right? So at initial stage, what happens? Because of the pyrogens, because of the interleukins, there is a slow rising of temperature. Suppose in first day of infection, normal temperature is 37 degrees centigrade. In the first day of fever, the temperature rise at level of 39 degrees centigrade. This is a fever, but hypothalamic set point is at 40 degrees centigrade. So the hypothalamus sense that this is not fever, this is hypothermia, because the set point is at 40 degrees centigrade, right? So due to that mechanism, there is cold stage, there is peripheral vasoconstriction. Hypothalamus try to conserve the body temperature by vasoconstriction. That means, so intense chill and rigor happen. So this is the first stage, cold stage. After that, after 2 to 3 days, the temperature slowly rises above the set point, suppose 41 degrees centigrade. Then the hypothalamus can sense it as a fever or pyrexia. Then this is a hot stage, just like fever, okay? And the last one is the sweating stage. So after certain period of time, after 2 to 4 hours, what happens? The hot stage is 2 to 6 hours. The initial stage is 15 to 60 minutes, that is cold stage. The hot stage is 2 to 6 hours, and the sweating stage is 4 to 6 hours, right? So why sweating stage happens? Because after the hot stage, there is cytokine washout. The cytokine is washed out. Okay, and the hypothalamus temperature set point comes down to 37 degree temperature, 37 degree. But the core body temperature is still at 41 degree. Right? So there is a difference between the set point and the core temperature that leads to severing. So the hypothalamus now try to calm down the body temperature by the severing mechanism. Okay. So this is the mechanism. And regarding the fever periodicity, I have already mentioned 48-hour cycle, tertian malaria, most commonly in Vivax and oval and Falciparum in late stage. Quartan malaria, 72-hour cycle, Plasmodium malaria, and in early infection, in case of Falciparum malaria and Vivax malaria, fever may be continuous. The periodicity may only occur after 48 hours of infection, 2 to 3 days of infection. So this is a very important teaching point. Absence of classical paroxysm doesn't rule out malaria. In endemic area or endemic country like India, we should test malaria for malaria in case of in each and every fever, even day 1 also. ঠিক আছে? Each and every fever patient we have to test for malaria. So this is called fever profile. So this is severe malaria specific in case of Plasmodium falciparum. So according to the WHO guideline, any one if present, then we can call it as severe malaria. One is cerebral malaria, that is manifested as unarousable GCS or GCS less than 7, any convulsion, any seizures, any altered sensorium, along with the documented fever and malaria. Okay. Hematological, that is severe anemia, maybe with hemoglobinuria, hemoglobin less than 7, and along with that the parasitemia is more than 10,000 per microliter. Disseminated intravascular coagulation or spontaneous bleeding, severe thrombocytopenia, and hyperparasitemia, that is defined as more than equals to 5% RBC parasitized or more than 2,50,000 per microliter. Okay, and regarding metabolic parameters, hypoglycemia, blood glucose level is less than 40. Metabolic acidosis, that means pH less than 7.2 along with bicarbonate less than 15. Hyperlactatemia, that means lactate more than 5 millimole per liter. In case of kidney, if this is a case of AKI, acute kidney injury due to malaria, specifically falciparum malaria, creatinine more than 3 mg per dl or urine output less than 0.5 ml per kg per hour for at least 12 hours. ARDS or pulmonary edema, that means the PO2 FiO2 ratio is less than 300 and there are classical infiltrates at both the lung field. If the bilirubin is more than 3 with other organ dysfunction, and if the patient is hypotensive, severely hypotensive, that means the patient is in shock, systolic blood pressure is less than 80 or the mean arterial blood pressure is less than 65 millimeter of mercury. Any one of these if present, then we can call it as severe malaria. Okay, and we have to treat accordingly. So cerebral malaria, what are the definitions of cerebral malaria? One, if the patient is infected and diagnosed with malaria with unarousable coma GCS less than 11 and coma must persist at least half an hour after seizure. rule out post-ictal state. So after GTCS or any kind of seizure, there is a post-ictal state, but this post-ictal state remains stays less than 30 minutes. But if it is more than 30 minutes, then definitely there is a cerebral malaria. Exclusion of other causes such as meningitis and retinal whitening, vessel change or hemorrhage, abnormal posturing that is decerebrate or decorticate rigidity, papilledema suggests raised ICP, and so these are the criteria of cerebral malaria. So this is your long question. Cerebral malaria is long question. Okay. Pathogenesis I have already mentioned about the cytoadherence and the Rosetting formation and sequestration. Just this is mentioned here. And management I will discuss in my later slides. Okay. Other complications of severe malaria. So severe malaria may be hematological manifestation, that means severe anemia, acute kidney injury, hypoglycemia, black water fever or DIC. So these all are the categories of severe malaria. So these are the differential diagnosis of malaria. Okay, dengue, enteric fever, leptospirosis. In case of dengue, thrombocytopenia is more pronounced than anemia, and there is absence of splenomegaly. But in case of malaria, there is a splenomegaly. Okay. In case of enteric fever or typhoid fever, there is step ladder pattern of pyrexia and relative bradycardia. Okay. Leptospirosis, scrub typhus, these are the all differential diagnosis of malaria. Okay. So now diagnosis from your microbiology class, there are two smears we should prepare for diagnosis of malaria. One is thick, another one is thin smear. So what is thick smear? Anyone? What is thick smear? Why do you prepare thick smear and thin smear? Stand up. Can hear. So one is, so thick smear, actually in thick smear the RBCs are lysed. The parasite, we can see the parasite just directly under the microscope because of the lysed RBC. Okay, sit down. So this is useful for screening, has highest sensitivity, can detect low parasitemia as well, right? But this cannot identify the parasite stage. Whether in case of thin smear, the RBC are not lysed, there is a monolayer of RBCs and the morphologies are preserved, so it has higher specificity. So the higher sensitivity is thick smear, higher specific is thin smear. So in case of thin smear, this is used for species identification and parasite count. So percentage of parasitized RBC that indicates parasitemia. So more than 5%, that means hyperparasitemia. So this is specifical in case of Falciparum malaria. Severe, this is a criteria of severe malaria, more than 5% parasite. So rapid diagnostic test and molecular methods. We all know about the rapid diagnostic test. In case of two different species, there are two different antigen we can use. One is for Falciparum, another one is for Vivax. For Falciparum, the immunochromatographic stain we can use, that is PF-HRP2 protein, histidine rich protein 2. This is specific for Falciparum. And PF-LDH, that means PV-LDH, that means lactate dehydrogenase, is specific for Vivax. So market je amra ekhon kit gulo use kori, that consists of both PV-LDH and PF-HRP2. So by that we can diagnose both the PF and PV, Plasmodium falciparum and Vivax, by only one kit, right? But even after treatment completion, HRP2 protein stays inside our body, even after treatment completion. So that become false positive, right? So after completion of treatment, you should never do a kit test. Always do before to diagnose the disease, okay? So, but the gold standard is molecular method, that is PCR, polymerase chain reaction. This has highest sensitivity, used for species confirmation, resistant markers, but definitely not routinely done. So this is very important vector-borne disease control program algorithm. When microscopy is available within 24 hours, always use peripheral blood smear for thick and thin. This is the gold standard. In case of microscopy is available within 24 hours. But when microscopy is not available, use the RDT, rapid diagnostic kit. So ASA workers trained for RDT use plus ACT administration. If RDT is positive for Falciparum, treat with ACT immediately, and negative smear or RDT with a strong clinical suspicion, repeat that test after 24 hours. This is the diagnosis. So in my next class, I will discuss about the treatment of malaria. Okay. So any query from that part? This is a very important aspect of your clinical teaching, malaria. Okay, and even this is a very important long question.